Adrenal insufficiency often becomes a convenient, albeit heavy bucket, where every stray symptom gets tossed the moment a diagnosis is confirmed. Yet this instinct to centralize every health struggle under one label might actually be stalling the very recovery patients are desperate to find. It is a paradox of chronic illness. Getting the answer can sometimes stop the questions. When we look at the research, like the 2010 study published in the journal Clinical Endocrinology, we see that nearly 70% of patients with adrenal insufficiency are initially misdiagnosed, often with psychiatric or gastrointestinal issues. That long, exhausting fight for validation makes it incredibly tempting to view that hard-won diagnosis as the sole explanation for every headache, every dizzy spell, and every bout of fatigue from that day forward.
It's a natural psychological response. After years of being told your symptoms are all in your head or just stress, finding out your adrenal glands aren't producing enough cortisol, the literal life-sustaining hormone, feels like the ultimate explanation. Cortisol is the body's multi-tool. It regulates blood pressure, immune signaling, and glucose levels. Because its reach is so vast, its deficiency can mimic almost anything. But the danger, as outlined in recent insights from My Adrenal Life, is that we start to over-attribute. We stop looking for other legitimate issues because we've already found the big one. It creates this diagnostic tunnel vision where everything is viewed through the lens of hypocortisolism, even when the physiology suggests something else might be at play.
And that tunnel vision isn't just coming from the patients. Medical teams often do this too. Once a patient is labeled with Addison's disease or secondary adrenal insufficiency, any new complaint can be met with a, well, that's just your condition response. But is it? If we look at the statistics on comorbidities, the picture gets much more crowded. Research in the Journal of Clinical Endocrinology and Metabolism indicates that patients with primary adrenal insufficiency have a significantly higher prevalence of other autoimmune conditions. Hypothyroidism affects about 58% of these patients, and vitamin B12 deficiency appears in nearly 30%. If you're tossing your fatigue into the adrenal bucket without checking your thyroid or B12 levels, you might be ignoring a treatable cause of your suffering.
That's a critical point. The bucket gets full, and the more we stuff into it, the more we normalize symptoms that actually deserve a separate investigation. There's a distinction between symptoms caused by the absence of cortisol and symptoms that persist despite adequate replacement therapy. Standard hormone replacement is designed to mimic normal physiology as closely as possible. It isn't a magic cure that grants a perfect life, but it should, in theory, restore a baseline of function. If someone is on an individualized dose and timing schedule, meaning they're matching that natural circadian rhythm where cortisol peaks in the morning and they are still severely symptomatic every single day, it's a red flag. It suggests either the replacement strategy is off or there's a second or third player on the field.
Let's talk about that second player idea, specifically the overlap with things like dysautonomia. It's often hard to tell where adrenal insufficiency ends and something like postural orthostatic tachycardia syndrome, or POTS, begins. Both cause dizziness, exercise intolerance, and brain fog. But the treatment for POTS isn't more steroids. If a patient keeps upping their dose because they feel dizzy, they might be entering a dangerous cycle of over-replacement without ever addressing the underlying autonomic dysfunction. We see this in the data. Over-replacement with glucocorticoids is linked to increased cardiovascular risk and bone density loss. It's a delicate balance. You don't want to be under-replaced and risk a crisis, but you don't want to be over-replaced just because you're trying to treat a symptom that doesn't belong in the bucket.
The confusion around stress dosing plays a huge role here too. Cortisol is famously the stress hormone, so when life gets stressful, a deadline at work, a move, a fight with a spouse, there's a tendency to reach for extra medication, but physiologic replacement is meant to cover the standard stresses of daily life. Stress dosing, according to the Endocrine Society's guidelines, is intended for major physiologic shocks, high fever, surgery, severe injury, or persistent vomiting. If the daily grind requires constant extra steroids just to stay upright, that's a signal to look deeper. It might be a malabsorption issue in the gut, or it could be that the baseline dose timing isn't hitting the peaks and valleys the body needs. Or again, it might be a completely separate condition like anemia or a sleep disorder that is sapping your resilience.
It's almost like the diagnosis becomes a shield that prevents the patient from getting thorough care for other things. For example, the symptoms of menopause or even simple nutritional deficiencies can look identical to low cortisol feelings. If you have adrenal insufficiency, you're still allowed to have an iron deficiency. You're still allowed to have a heart condition. But if every time you tell your doctor you're tired, you both just sigh and blame the adrenals, you're missing the chance for a different intervention that could actually help. There's a real emotional weight to this, too. After fighting so hard to be heard, admitting that the diagnosis didn't solve the whole puzzle can feel like a defeat. It can feel like you're back at square one.
Actually, it's the opposite of a defeat. Acknowledging that the bucket is too full is empowering. It means the door to improvement is still open. If you assume all your pain and fatigue is just the unavoidable reality of adrenal insufficiency, you've essentially accepted a ceiling on your quality of life. But if you see it as just one piece of the puzzle, you can keep looking for the other pieces. We have to remember that health isn't one-dimensional, especially in the case of tertiary or steroid-induced adrenal insufficiency, which is increasingly common due to the widespread use of glucocorticoids for other inflammatory conditions. These patients often have multiple layers of illness, the original condition they were taking steroids for, plus the now suppressed HPA axis. You can't just look at the adrenals in a vacuum.
It's interesting how online communities can unintentionally reinforce this one bucket mentality. You see it in forums all the time. Someone posts about a new symptom and 10 people comment saying, "Oh, that's just the AI, you need to up your dose." While well-intentioned, that kind of groupthink can be harmful. It normalizes a lower standard of health. Instead of encouraging someone to see their cardiologist or get a sleep study, the community collectively pushes everything into the same bucket. It's why we need to advocate for whole-person care. The goal shouldn't just be managing a diagnosis. It should be optimizing the person's entire biological system.
And that requires a level of nuance that's hard to find in a 15-minute doctor's appointment. You have to be an expert on your own body, but also be willing to let go of the AI-only narrative. If the science shows that replacement therapy should allow for a relatively normal life, working, parenting, traveling, and you're miles away from that, the answer probably isn't just more cortisol. We have to look at how different systems interact. For instance, the way cortisol affects your fluid and electrolyte balance. If that's off, it's not just an adrenal issue, it's a metabolic and cardiovascular issue. By pulling things out of the adrenal bucket and putting them under the right microscope, we actually get closer to real solutions.
It seems the core of the problem is the non-specific nature of the symptoms. Fatigue, dizziness, and nausea are the chameleons of the medical world. They change their meaning depending on the light you shine on them. If you shine the light of an Addison's diagnosis, they look like cortisol deficiency. If you shine the light of a thyroid disorder, they look like hypothyroidism. The key is to keep multiple lights on at once. This isn't about minimizing the reality of adrenal insufficiency. It is a life-threatening, serious condition that requires constant vigilance. It's about respecting the diagnosis enough to not let it become a dumping ground for everything else.
Precisely. It's about clinical accuracy. When we misattribute a symptom, we delay the correct treatment. Think about something as simple as sleep apnea. If an AI patient is exhausted and they assume it's their morning cortisol trough, they might keep adjusting their meds while their airway is literally closing at night. No amount of hydrocortisone is going to fix a mechanical breathing issue. Or consider the psychological side. Anxiety-like symptoms are a hallmark of both low cortisol and high cortisol. If a patient feels anxious and assumes they are low, but they're actually experiencing the side effects of over-replacement, taking more steroids is going to make the problem exponentially worse. We have to be willing to look at the data, the labs, and the full clinical picture.
There's also a significant historical context to why we do this. For decades, adrenal insufficiency was a death sentence. Once synthetic corticosteroids became available in the mid-20th century, the focus was purely on survival. For a long time, not dying was the benchmark for a successful treatment. But as we've moved into an era of chronic disease management, the benchmark has shifted to quality of life. The 2016 review in Frontiers of Hormone Research points out that even with standard replacement, mortality remains higher and quality of life remains lower than in the general population. This suggests that our current standard isn't quite good enough, or perhaps we are failing to treat the comorbid conditions that are dragging those numbers down.
That's a vital shift in perspective. If we only aim for survival, we miss the opportunity for vitality. By separating the symptoms, we can address each one with the specificity it deserves. If the fatigue is anemia, give iron. If the dizziness is dysautonomia, increase salt and fluids or use specialized medications. If the brain fog is a side effect of a different medication, address that. This decluttering of the adrenal bucket allows for a much more targeted and effective healthcare strategy. It moves the patient from a passive recipient of a one-size-fits-all steroid plan to an active participant in a complex, multi-layered recovery.
And that realization is actually quite hopeful. It means that just because you have adrenal insufficiency, you aren't destined to feel terrible forever. It might just mean your current health plan is missing a few chapters. We've seen that the HPA axis, the hypothalamus-pituitary-adrenal axis, is incredibly sensitive. Even inhaled or topical steroids can cause suppression in some people, a form of secondary or tertiary AI. For those patients, the overlap is even more confusing because they are often managing the original inflammation alongside the new hormonal deficiency. They have to be even more careful about what they put in that bucket.
It all comes back to the idea that you are more than one diagnosis. Your body is a system of systems. When the adrenal system falters, it definitely sends shockwaves through the others, but those other systems can also have their own independent faults. The most supportive thing a medical team or an online community can do is help a patient hold those two truths at once. Yes, your adrenal insufficiency is a massive, life-altering factor, but no, it is not the only thing happening inside you. Keeping that distinction clear is the difference between a life of managing a label and a life of seeking actual wellness.
It's a middle ground that feels uncomfortable because it requires constant reassessment. It's much easier to have one answer for everything. But human health is rarely one-dimensional, and chronic illness certainly isn't. When we stop putting everything in the adrenal bucket, we stop normalizing the struggle. We start asking better questions. We look at the sleep, the nutrition, the other hormones, and the autonomic system. We start treating the whole person again. That is where the real progress happens, in the space between the diagnosis and the actual human experience of living with it.
Ultimately, the goal of replacement therapy is to get you back to your life, not to become your life. If the illness has become the primary lens through which you see every single day, it might be time to dump out the bucket and see what actually belongs there. You might find that some of those symptoms have been waiting for a different answer all along. And finding those answers doesn't make your adrenal diagnosis any less real. It just makes your path to feeling better much clearer.
The complexity of the human body means that a single label, no matter how hard won, can never tell the whole story. By looking beyond the adrenal bucket, patients and providers can move toward a more nuanced, effective form of care that respects the reality of the condition without being blinded by it. If you found this perspective helpful, consider sharing this episode with someone else navigating the complexities of chronic illness. It might be the push they need to look for that next missing piece of their own puzzle.